So I was asked to give the clinician's perspective. We could change that to one clinician's perspective because it's going to be mine, and I hope some of you will share this perspective. But one thing, first of all, you need to know that these are my disclosure. The one that's maybe more relevant is that I've received consulting fees from Abiomed, who does support system, and if there's any other company who doesn't see his name here on the slide, you can come to me. We can fix that later. So in terms of tools and medication on how we treat, what's innovation? Well, first of all, it's the tools and medication to treat our patient. We have in Canada, and as was beautifully said by Ken, people who have been involved in basic research. Just to cite Brad Strauss recently with his collagenase, physician who has been involved in the industry. Chris Buller with Abbott Vascular developed tons of wires, vascular solutions, Soundbite. We have like startups here in Montreal where we're developing new devices. There are innovation, and there are also innovation in methods to treat patients, often against the current school of thoughts. But when we're talking about value-based medicine, and it was outlined very nicely by previous speakers, it's a balance between, cost, sustainability, efficiency, but most of it, when you see what you're able to read from the back, is outcomes. This is the biggest term that you need to see is outcomes. And the physician's fundamental perspective on innovation, and that's, I think we all share this value that medicine should place high value on innovative strategies. So because health assessment, as currently being done, is usually lagging behind recommendations. It's very difficult to say, your next strategy is going to be a win when you review things that are been done for 5 years ago. Physicians want access to technology to improve outcomes. Innovation should help provide best care to the patient within a reasonable budget provided for sure. We should use also cost comparisons that make sense, and I'll give you some examples. And we should not try, as physicians, to save money on case-by-case basis. The policy level, the decision should be taken at the policy level to provide supply or not. We are not asked, we should never play the double agent. If I am treating a given patient, this patient has only one advocate in this health system, is me. I am in debt to do something for that patient, to provide the best care I can do for that patient. Innovators versus evidence-based medicine. We think, innovators are think outside the box thinkers. If this doesn't work, we need to do differently. You'll see some examples of this. It's also this progressive versus conservative thinking, but we all have barriers that are sometimes the peers, but also the budget. You need to understand how it works in Canada as well as a physician. In Canada, management, the money does not follow the patient usually. We have silo budgeting. Managers are rewarded by meeting their budget objectives, whereas physicians rather want to do more procedures. So we have this tension. And there are non-coherent budget decisions that make physicians skeptical about management over time. For example, when you're giving a hard time by your administrator because you use too many wires, FFI wires, well, you basically know that you're saving a lot of money to the hospital because these patients don't stay as long in the hospital, and it's a much more expensive money. And sometimes you're given a restricted access to these devices that are actually cost-saving. And in the US, well, we know money follows the patient. More care becomes more revenues. It's got other problem. Obviously, equity is part of it. But at least this model is a bit more coherent. I've came to that reflection over time, which is is it pure cost effectiveness that drives practice? Or is it affordability? Well, cost savings are really, and I don't mean to maybe the Ministry of Health, but in the management, the ones who come to you and say you're doing too much of this and that, they're really looking at stuff that can save money, not to increase spending to get more value. This is what we're facing. This is the main objective, and that's, You know, for example, with the tenders that drove the DS cost to $200, there's been no reinvestment at all in our current budget, such as in TAVIs or anything. And actually, if you see the budgets in interventional cardiology of melting years after years, or not, because even if we've been able to bring the cost down from a DES, first talk I gave to that symposium was cost effectiveness of DES. It sounds like so dinosaur to talk about this right now, but that's not, we're talking about like a few years ago. I'm not that old, right? So 2 examples. TAVI in moderate risk and protected PCI, you've heard about that. But you know, we all know TAVI there's a highest constraint in access in Canada. We're basically focusing a lot of non-surgical candidate in the vast majority. But that means, in consequence, a lower risk still undergo surgical AVR with 2 times the risk of stroke and sometimes mortality. So it's all a question of affordability right now. It's not a question of cost effectiveness. You're surely aware of the CERT-TAVI study that showed quite a dramatic reduction in the risk of stroke with TAVI versus surgery. And if you look at all the other endpoints at that study, there's like a reduction in stroke, transfusion, acute kidney, shock, atrial fibrillation, all in favor of TAVI, compared to obviously a couple of increased risks like vascular complication. We're still awaiting the cost effectiveness study of that, but I'd be very surprised that it will, you know, in the end it will depend on the cost and the cost difference, but it's all dependent on the cost. It has not much dependence on the value, because we all understand the value is there. And if a TAVI would be $2,000 more than a surgical EVR, we wouldn't be even here to discuss about this tension we're facing. Protected PCI or not, we've seen cases this morning. Just share a patient example did last week. 85-year-old lovely grandmother. She's got an non-STEMI. She's got a porcelain aorta and 3VD and the FF25. She's turned down by surgery. That's her anatomy. So you can see the distal left main is critically stenosed with a 95 circ, like slow flow in the circ, and a CTO of the right. In the old days, if you dream of doing that PCI and expecting that the patient would be alive, it's impossible. This patient is too high a risk. So we did protected PCI on that patient. And finally, we're able to open the circ, open the LED, open the right with good result. But and you might be aware, so I'm fortunate so far in Quebec, I managed within my very melting budget to get the funding to do those cases. But the OTAC has recommended that percutaneous ventricular device should not be reimbursed in Ontario. But the devil's in the details. You know, there's no randomized trial or prospective observational study with a control group that has studied Impella CP or Impella 5.0. And therefore, they focus a lot on Impella 2.5. They're not associated with improvement in mortality, and therefore, their cost-effectiveness analysis is not good. But my old epidemiology teacher in Harvard used to say to me, that when you assume, you make an ass out of you and me. And what should be considered from policy influencers that nobody uses Impella 2.5 anymore. This device has been supplanted by other devices. And 2.5 liter versus 3.5 and 4.0 we get now is the difference between life and death. And second, the important key opinion leader are not usually in the reports. They may be consulted, they may have a line, a personal communication, but they're not there to sort of being involved. And I welcome this sort of shift that I hear, at least from Inés, that we may be more involved in the get-go to be partners. So. But you know, what we need to understand about Impella, I'll be talking a bit about Impella right now, is that It's a tool to achieve difficult but now possible complete revascularization that would not have been possible otherwise. And surgeons have been using protection for years, and now we understand the value of it. It has high validity for most interventional cardiologists. It's got a very high cost. It's compared to non-protected PCI, but is it the right comparator? That's a blood pressure during one case. I want you to follow this. These are minutes flowing, okay, over time. Look at the pressure. Pressure is going down. Patient has an impella, and the pressure is going down. You can see here, whoa, it's in the 60s, and it's going back. Oops, a bit of, oh, and that's a few minutes. Oops, that's 40, and then coming back with a bit of adrenaline. This patient, during all cases, this is a sort of a flat line here, coming back up. So this is the sort of the rocky ride you would expect without an impella. It's a code blue. Forget about it. You have a team with a code blue. So it's a difference between life and death. So the clinical dilemma we're facing is 3VD, LV dysfunction, accepted by surgeon. Okay, we're willing to spend $25K 50% of the time, but might be sometimes 40 and 50 because these patients are not the classical. They may stay long in the hospital and everything, or you have no CABG. But then if you look at no CABG, you either do medical therapy. Well, the cost will depend on how you die. If you die fast, it doesn't cost much. But if you die by coming back a lot to the hospital, you may consume a lot of resources. Or you do PCI. You may do the unprotected PCI, which costs you maybe $2,000, mortality of about 20%, I would estimate. Or you do protected PCI, it's going to be 20K at a mortality of 5. But if you streamline to a more logical comparator is if that surgeon had said yes, the system would have spent at least $25K on that patient. Why should I be asked to save money on that patient compared to what it was supposed to be spent on that patient? So that's the way I manage it with my administration and saying, I don't have to kill patient on the table. You guys were willing to spend the money. You don't even know. But if the patient had said yes, you were willing to spend maybe up to $40K on that patient. Just to review a bit of what are the criteria for protected PCI, it depends on the money you have. In Canada, it's pretty much and. You need a disaster LV with horrible ventricle because we don't have reimbursement. So we use more and more of those criteria to decide who will be dealing with percutaneous coronary intervention, protected cases. Here's another case, 80-year-old, angina and heart failure, non-STEMI in January, failed attempt of CTO PCI of the LED. He's got an EF of 20%. On MRI, it's not even 20, it's 13, and everything is viable, everything. It's turned on by surgery because of age, poor distal target, and the EF is poor. So what are the options? Well, on the angiogram, you can see the right has got some moderate disease. We did an FFR. It was positive. You can really readily appreciate that the LED is a CTO, very calcified. And we're not crazy. We didn't start by doing an impella right away. I started with doing an antegrade procedure, and I could not even crack this lesion. So if I'm out to do a rotablator, I need to have some support. So at this point, we installed the impella, couldn't work. We had to go from the right coronary to open the LED, so we did a retrograde procedure. And with this retrograde procedure, we were able to, after fixing the right, because it was a donor artery, we're able to open the LED and finally opened up the left system with good result, and the right system was good. And this patient has been doing really fine, and we're looking forward to look how his LV will recuperate because it was all viable, so we expect it should be the case. So CHIP is often, in Canada, a very difficult case turned down by surgery that will likely not tolerate plumbing work. And that's basically how we define it. It's what I also define at my department of desperate causes. And, but you need also the skill set to treat those cases. And I hear the point that you don't put an impella just to fix an OM branch. You should be aiming at doing a complete job as much as a surgeon would be doing. I want to finish on a case, another example of a patient from my department of despair. EF of 25%, recent non-STEMI, severe left main and circ, CTO of the LAD, turned down by surgery, and now he's sent. So that's the sort of anatomy he had at baseline. The left main is critical. You don't see any LAD, so you can see here how few red blood cells go at the same time through that left main. And in the old days, you would not think of doing that case without even a balloon pump, because the risk would be prohibitive. You can see the LAD filling by collaterals. And again, if you look really at that case, it's an intervention on unprotected left main, multivessel disease, distal left main bifurcation. So just to show you why we're using protection, because so that's an impella that's in place. You're fixing the right, so fix the right, that's okay. But the left system requires a lot of work. So it's just to help you understand why we're doing it. It's got a CTO, it's got a left main. So we got to first balloon the circumflex, get into the circ, get into the LED, cross the LED, and at some point, so the LED, we were able to recanalize the LED. So there are many, many steps. You instrument a lot the coronaries. Finally doing the PCI on the LED, you're not even done, because now you're changing the chapter. You're not into a left main PCI. And then now once you've opened the left main, you're kissing, now you're bifurcation, you're doing all of this. And finally, you're able to reconstruct the coronaries. And that's feasible. That's not impossible. These cases can be done only if you have support. If you don't have support, they cannot. I will just skip. Can you go back and click this, touch this little blue button on the right, please? So in conclusions, clinicians should place high value on innovative strategies. Physicians want access to technology that improve outcomes, provide the best care of the patient. Physician wants to treat their patient the best possible way. There's no policymaker that will ever come and defend them of consequence of underuse. And that's one thing we have to, and we cannot play the double agent role. And all savings, I hope so, should be better reinvested in minimally invasive care of an aging but very active population. Thank you very much for your attention.